From Columbia University, the Gray Matters CU podcast is a show about the goings-on of neuroscience professors on campus and the motivations and explanations behind their research. My name is Lila Bear, and I'm the executive producer of the Gray Matters podcast. On the show today, I talked to Professor and Dr. J. John Mann about his work leading the Ketamine project at Columbia University. Dr. Mann is a professor of translational neuroscience, former vice chair for research in the Department of Psychiatry at Columbia, and the former president of the International Academy of Suicide Research. He is trained in psychiatry and internal medicine, has a doctorate in neurochemistry, and has published over 450 papers, and so much more. But listing all of his achievements would take a whole episode in and of itself, so let's jump in. Can you just walk me through a little bit about how you got to where you are and what position you're in right now?
Yes, so I'm trained as a physician. I've specialized first in internal medicine and subsequently in psychiatry. And I did a doctorate, like an MD, PhD in the US. I sort of meandered with those qualifications into the field of translational neuroscience, which really means looking at the brain with a variety of tools, trying to, in a kind of a dialogue with research that's done in animals, mostly transgenic mice, non-human primates, things like that, to try and understand the pathogenesis and develop better treatments for psychiatric disorders. My particular interests are mood disorders and suicidal behavior.
I am really interested in your research with the ketamine program, and I was wondering if you could start off and tell me a little bit about what you're doing there.
So the reason that ketamine is so interesting is that a number of years ago, it was reported to have very rapid antidepressant effects. And that, when I say rapid, I mean working in hours or a day or so. And whereas most other antidepressant treatments that we have, either medications or different types of brain stimulation therapies, take weeks to work. So a treatment that can work in hours or a day or so is very different to a treatment that takes weeks to work. Most medications, and ketamine is a medication, don't work in more than half of the people that they're administered to, usually less than half. So their degree of antidepressant effect isn't that great, and although over weeks and longer, it can sometimes become quite robust, but it takes a while to develop. So slow to develop, and lower response rates made ketamine a particularly interesting medication because it had three characteristics. One, it worked fast. Two, it worked for a lot of people, including people that had failed clinical trials with other medications. Three, the degree of improvement in this very short time frame was robust, not modest. So my idea, because I'm not only interested in pushing forward the frontiers of what we can do with in terms of the treatment of depression, are also to learn something about what's going on in depression and how very, how more remarkable groundbreaking treatments work, so we can develop even better treatments. Ketamine does have some side effects, and potentially understanding how it works could eliminate those side effects with a second generation treatment, if you like. And we developed this idea. We would put people in a scanner, in an MRI, and we would scan major neurotransmitter systems like GABA and glutamate while they're depressed. And then we would start administrating ketamine, in the research world, we usually give it intravenously into the vein slowly over 40 minutes. And very often by the end of the infusion, and certainly by the end of 24 hours, many of these people, not all of them, but many of these people are feeling way better. It's not like maybe I'm feeling a little better. It's, wow, I feel really different and a lot improved. So I thought, all right, this is a bit like let's watch the first steps. What are the first things that ketamine does that make people better? And there's a lot of focus on these two neurotransmitter systems as potentially its immediate targets. And sure enough, we saw immediate effects. With regard to glutamate, we saw an effect that, first of all, we saw a relationship. We did a double-blind, randomized clinical control trial with two placebo or different doses of ketamine. And we found that there was a very strong relationship between the dose and the clinical response. The dose was linearly, closely related to the degree of clinical response. They did better on certain doses and worse on others. Then we asked the question, do these doses reflect the impact on, say, glutamate or GABA in the brain? And the answer was yes. Then we asked the question, is the relationship to of clinical response to dose mediated by the impact of dose on these two neurotransmitter systems? We found that the reason dose effect on improvement in these patients was mediated by the effect of the dose on the glutamate transmitter system, but not on the GABA transmitter system. That means that theoretically, we could find other medications that do what ketamine does to the glutamate system. And the degree to which they do the same thing as ketamine does probably will allow us to even predict how good of an antidepressant these other medications are going to be. Not only are we going to say, wow, it does something, the same kind of thing as ketamine, but based on the degree that it changes the glutamate system in the same direction that ketamine does, we can even potentially predict how good of an antidepressant it is. So that was a huge thing to have observed in this study.
Is the ketamine treatment that you're working on, is this supposed to be a long-term or a short-term treatment?
There's a bit of a debate in the field, but our approach here at Columbia, after having conducted the only 3 randomized clinical control trials funded by the NIMH, is that you can use ketamine in one of 2 ways. You can use it to augment the antidepressant or fix the lack of antidepressant effect with oral standard antidepressants. So they're taking their meds, we review them, we optimize them, and nearly all of them can just be continued, and then you just give them the ketamine. And you give 1 dose, 2 doses, 3 doses, 4 doses. If they don't get a lot better after 3 doses, they're not going to respond. So you can abandon ketamine. But if they get a lot better, you then have a choice. You can stop the ketamine at that point and just continue with the optimized oral medications. Or you can go on with the ketamine, 2 doses a week for 3 weeks, 1 dose a week for 3 weeks, and then 1 dose every 2 weeks for a couple of weeks, and then 1 dose a month for a couple of months, and then stop. Right, so some people like to give a course of ketamine. We like to give a few doses and see if we can bump up the response to a satisfactory level and then sustain it with manipulating the oral medications. Every now and then, some patients, it works for a lot of patients, some patients need some rescue ketamine if they slip backwards too much, but many people can just be maintained without having to do that. So ketamine, in essence, for most people, is a short-term treatment. You either get the short-term course that I described, or you just get, the 3 or 4 treatments, and that's it. Long-term treatment is going to be oral medications.
Just to clarify, the first way is to enhance the antidepressants the patient is already on. And then the second way, I don't understand yet.
So some people will, want to give like a full course of ketamine and hope that the person emerges at the other end pretty robust and not needing too much more, not needing ketamine, but now most oral medication regimes are going to work for this patient. But we prefer to optimize the oral regime, different combinations, different doses, et cetera, and when we do that, we feel that most people don't need all of that, that whole course of ketamine that can go on for weeks or months.
You mentioned side effects. What are some side effects that you've seen?
Okay, so the side effects for the 3 main side effects that people get when they take ketamine is, first of all, they get a tripping experience. After all, that's why people use it as a, party drug,
right?
Or sometimes even abuse it. Because they like the tripping experience. Most patients who are depressed do not like that tripping experience. For them, it's unpleasant, unsettling, and they put up with it. But pretty much after you stop the infusion or an hour or 2 after the intranasal administration of the ketamine, it's gone. Those symptoms are gone. They're tolerable for most people, even though they don't love them. Second side effect is that it produces a rise in blood pressure. For most people, that rise in blood pressure is pretty mild. It would be asymptomatic unless you wouldn't even know unless you measured your blood pressure consistently, or somebody did through the ketamine administration period. But there's definitely a rise in blood pressure. Exceedingly rare that anybody needs medication intervention to drop the blood pressure because it's excessive. But one needs to be aware of the fact that it's a good idea to monitor the blood pressure so that it's okay. And the third side effect is that people get nausea. That's milder with the intravenous infusion than it is with intranasal. And sometimes, very rarely, they may vomit. So you need to warn people that they may have these experiences. In our when we administer ketamine, we really have to do any interventions with anything for either any of the 3 things that I've just mentioned: tripping, nausea, or blood pressure. We don't use ketamine in people who have psychotic features. Some patients will have this psychosis significantly aggravated, or sometimes the symptoms will emerge de novo if they take certain medications, stimulants like amphetamine and hallucinogens, LSD, fentanyl, certain other drugs like that, that are known to be hallucinogens, and ketamine.
Just to go off of that even more, there are lots of drugs that people take recreationally, like ketamine. How did you discover these alternate effects of ketamine?
So here's the thing. So there was a group at Yale that was studying schizophrenia and trying to understand how schizophrenia is caused. And so they were giving normal volunteers sub-anesthetic doses of ketamine to induce a psychotomimetic effect. Now, they knew that it wears off rapidly. It doesn't produce schizophrenia. It wears off rapidly. And they're only giving, 1 dose, and it's in the lab. And they're doing all kinds of studies to understand the biology of psychosis. And they happen to give these doses to people that later reported, actually, I didn't tell you this because it didn't seem relevant, but I was actually in the middle of this terrible depression that I've had for months, and it's gone right away. Yeah. So they said, wow, are you sure about that? And so they had a few cases like that. And then they tried it deliberately in depressed patients. and they found it had an amazing therapeutic effect. That's how it was discovered.
So back to the effects of ketamine, it can have such an immediate effect, but how long does that last before you have, let's say you just are administered one dose like these?
Yeah, so we've done that plenty of times. We know the answer. For 5 to 7 days, the full benefit is sustained.
Okay.
And after that time, it begins to gradually, not precipitously, but gradually fade away. And if you wait long enough, it'll be all gone, which is why people tend to, when they give it initially as the main treatment, and sometimes the only treatment, they will give 2 doses a week, because that's like Monday and Friday. They're sort of doing it every 5 days. They're trying to stay within the window where people feel good so they don't go backwards.
So I know we're closing in on time. One final question about ketamine. What do you see as the future? What do you envision?
So in our study that I described to you at the beginning of this podcast, I mentioned to you that we've been looking at the relationship to dose and so on and so forth. And dose does have some relationship, so not very strong, but to side effects. But here's the really interesting thing. Those hallucinogenic tripping side effects are unrelated quantitatively to the degree of antidepressant effect, which means that it indicates that you could theoretically have a version of ketamine that doesn't produce any of this tripping or hallucinogenic effect and should be just as good as of an antidepressant. And that is what we're looking for now.
I recently watched the show. This is just a crazy interlude where someone took ayahuasca. There are so many drugs out there that probably have the potential to positively affect people if used in the correct dose. Do you think that's true?
I have no doubt there are medications out there that are as effective as ketamine, but some of them are worse than ketamine because their propensity for psychosis induction and hallucinations are much more potent. That's not a great way to go, right? That's like the opposite direction to the one that we're trying to go in. And then there will be medications that will hopefully have the same potent, rapid antidepressant effect of ketamine without these psychotomimetic effects. I guess what I'm saying to you is that our research suggests you do not need the psychomimetic effects in order to have the antidepressant effect. That is a crucial fact that is being lost in this discussion of, should I be taking psilocybin? Should I be taking, whatever other, rare South American plant-derived, fully investigated compound to treat my depression? There's a better direction to be going in. That's the direction we're trying to go in. The other direction is not what the data indicates is the appropriate direction to go in.
Okay, I'm just a huge fan, and I'm so glad we were able to have this conversation. I just want one more thing from you, which is if you could give one piece of advice for a student in the STEM field. It doesn't have to be neuroscience.
Find the best professors and mentors that you can. Not everybody is the same caliber, and learn from them.
Will do. Okay, well, thank you again so much. I appreciate you spending your time talking to me.
Sure, Lala. You're the future.
Yep.
We're here to help you make the future better.
Well, that's the goal, for sure.
Thanks for listening to the show this week. If you want to request a neuroscience professor to hear from, you can do so at our website, graymattersjournalcu.org. If you want to follow the show on social media, our Instagram is at graymatterscu. This episode was produced and edited by Lila Bear. Research was done by Melody Fang and Anna Sofia Rico Rozo. Our production staff also includes Sam Hutchinson, Mariana Mosen, and Chloe Wong. Our executive producer is Lila Bear. I'm Rochelle Vaintrub, and you've been listening to Gray Matters CU podcast.